Hi, I'm Dr. Steve Elias, and welcome to the veinPODCAST. Respect the elders, embrace the new, and encourage the improbable and impractical without bias. Welcome to the next veinPODCAST. This veinPODCAST, we're having people, which I've already been told before we started recording, actually still use stethoscopes. So these are everyone here is vascular medicine. The title of this, Thom was showing us one too. The theme of this is the vein specialist really needs a vascular medicine friend. And with us are four very well-known vascular medicine specialists who also deal with vein disease. When I say your name, kind of raise your hand a little bit. We have Thom Rooke from the Mayo Clinic, Suman Wasan from University of North Carolina now, Yogendra Kanthi from University of Michigan, and Raghu Kolluri from Ohio Health. And all of them have participated with many of the vein meetings. They speak a lot about this. But I want to take a step back here and ask you guys, let's start with Suman. Suman, give me the lay person. Try and explain to a lay person what a vascular medicine specialist is. Not from the vein world, but just in general.
Well, it's a good question because I just actually went up to the UNC and tried to tell them what a vascular medicine specialist is. Right, so a very timely question. So I would say the vascular medicine specialist is one who sees patients with diseases of the blood vessels. And as opposed to a hematologist, which is the distinction I'm making of late, who sees diseases of the blood. So anything to do with a blood vessel, medical disease, imaging, that is what a vascular medicine specialist does. So exclusive of the heart, we're the plumbers, and we're the ones who take care of the diseases of the blood vessels. That's what I would say in a nutshell.
Steve, if I could toss something in there, I would just point out that, we have all of these surgical specialties that everybody's so very familiar with. We've got medical counterparts for all of them. For general surgery, there's general internists. For cardiac surgeons, there's cardiologists. I think of the vascular medicine specialist in many ways as sort of being the medical counterpart for the vascular surgeons. It's a way I often explain when I'm talking to lay folks or to other physicians that really don't understand what I do. We do for vascular surgery what other specialties do for their surgical counterparts.
All right, and just to follow up on that, that's a great point, Thom, that as is cardiothoracic surgery is to cardiology and urology and nephrology, vascular surgery is to vascular medicine. So I think that is a great way to say that.
Yeah, no, I like that. I mean, I can conceptualize that as well. I mean, back in the old days, I would say to people, the one good thing about being a vein specialist is you don't have anybody competing with you. There is no medical counterpart. But then you guys came along, but we're talking 25 years ago. So that's good. No, we need you. We need you as a friend. That's why I have you here. You're friends. Yogen, anything else to add to that?
Well, I would echo Thom and Suman's thoughts. I think of it as when your kids take the SATs and they have to study analogies. Vascular surgery is to vascular medicine in the same way that cardiac surgery is to cardiology. And it allows really a very good partnership between these two specialties that allows us to really provide much more comprehensive care to patients. And the partnership is something that probably goes on for the life of the patient. So instead of them having one provider, they probably have a couple of them that can manage their diseases in the long term.
Yeah, no, that's a good point. So now, Raghu, give me a sense of what type of training, what are the various, is there only one pathway to becoming a vascular medicine specialist, or are there a few?
So there are a few pathways. Steve, thanks for arranging this. The type of pathways that I think of mainly, as I was describing to one of my surgical colleagues with an SVM, is one is internal medicine pathway, where you could do internal medicine and then do vascular medicine fellowship. And then The other main option is to do cardiology and then do vascular medicine. So you got two of each of us on this call here. Yogan and Thom are cardiology vascular medicine specialty route, and Suman and I are internal medicine vascular medicine route. So there are few exceptions, but largely those two are the pathways.
All right. So it's not as if you need to do something before, and there are fellowships in vascular medicine. It's not as if you can get on a vascular medicine path from medical school, per se. Is this correct?
Yeah, it's a fellowship program. Yes, you're right. Yeah. And we celebrated our 30th SVM annual sessions last year. So we're just about as old as AVF is, maybe a year or two behind, but about the same age. And in terms of the specialty as such, Thom would probably have a better historical perspective than I do, because as you can see from his hair, he is slightly more mature than I am. But at least in the Cleveland Clinic, vascular medicine has been existent since the mid-1960s.
Oh, okay.
We laugh about this at Mayo because we hired our first vascular medicine physician in the 1920s. He was one of the first 6 internists that was hired at the Mayo Clinic. We hired him 2 years before we hired our first person who specialized in cardiology. So we laugh at the other cardiologists that we're actually the oldest branch of the cardiovascular medical tree here.
All right. Now, let me ask you that in the vascular medicine world, then, what percentage of people, I know Suman and you all said you treat diseases of the blood vessel. Does everyone in vascular medicine treat diseases in a medical side and in a procedural side? Or are there some vascular medicine specialists who are really non-proceduralists and some who are proceduralists? And if you give me a sense of that, then what percentage would you say are proceduralists and what are really just non-proceduralists? Well, let's start with, Raghu, since your mouth is already moving. Go.
Just from the society standpoint, SVM, approximately 50% are actually interventionalists. And who have cardiology and interventional cardiology training too. There are some of us, like Suman and I, who do superficial venous interventions, okay? And the rest are basically non-proceduralists, like Yogan is. I believe Thom does sclerotherapy. Are you still doing that, Thom? Or
I gave that up, but I did do in my career like about 18,000 patients.
Yeah,
so, yeah.
Some ridiculous number. I thought 20,000, but
I'd have to recount them.
Yeah,
might be 20,000 by now. I stopped counting at 18.
Yeah. So we have people who are preventive internists, if you would, so who do preventive care and atherosclerosis. We have cardiologists who do that, who are trialists and do preventive PAD, write guidelines and those type of things. And then we have venous specialists like us here. Yogan, for example, does basic science, which is a big deal, which is a big part at University of Michigan, both in vascular medicine and vascular surgery, as you know. The rest, some of us do wound work too.
All right. Suman, anything to add to that?
I think the core training is internal medicine. In fact, over the years, as we've developed the specialty, we've wrestled with who is eligible to complete vascular medicine fellowship training. And the commonality, as Raghu has expressed, is internal medicine board certification. Now, there are a few exceptions in training at the Cleveland Clinic, et cetera. but core training is internal medicine. And then you can come in after cardiovascular or actually other subspecialties. For example, we're getting ready to take a hematology fellow who has done 2 years and wants to do her third year here at UNC through a fellowship grant, who's going to spend a year with me and Stefan Moll doing vascular medicine. So the core training is internal medicine. Some go on to do procedures through cardiology. As Raghu said, he and I do superficial vein procedures, but internal medicine training is sort of the basic to get into vascular medicine.
All right. All right, good. Now, let me just ask you a little bit, if you can, don't worry, we're not going to hold you to this, but when you guys sit around, talk amongst yourselves, do you say to yourself, I just wish those vein specialists or vascular surgeons would realize how much we can help you, would stop trying to be a vascular medicine, would give me what would you want from a vein specialist or a vascular surgeon that either that we should be doing or that we should stop doing from a vascular medicine viewpoint? This is a tough one. So I'll give it to Yogen.
I was worried about that after I should have spoken up earlier. Maybe I would be out of the rotation. But I think, well, so Steve, full disclosure, when I was in medical school and looking at residencies, I had to choose between two things. And one was either being a vascular surgeon or being a vascular medicine doc. So I think these two are so closely aligned with one another that when a vein specialist is doing work I just want them to call. And then feel free to call us and ask how we can help. Sometimes it's not just managing the veins itself, but perhaps there are other metabolic diseases or other risk factors that need to be managed for the patient that have longitudinal implications. And so we're happy to do those things. I think that's where the synergy really gets exciting.
Yeah. All right. So Raghu, is there competition at your place, or how have you decreased the competition between vascular vein specialists or vascular surgeons who do vein procedures versus you guys who deal with the superficial vein? Are they?
So within Ohio Health, we are salaried physicians, Steve. So we just do whatever we do best. So if I have a large varicosity that I think it would be best served by excisions in the OR with better control and that kind of stuff, I just send those patients to my vascular surgery colleagues who might do an RFA or a laser, and then take out the large varices in the OR. And they will send me patients for perforators, subalcer, foam sclerotherapy, and that kind of stuff. And that's within Ohio Health. Now, outside of Ohio Health, within Central Ohio, where our practice is, there are a lot of vein centers, and it's a different type of referral pattern, as you can imagine. That most of my patients are C4 through C6s, because, like you, our vein center is located within the wound center. So we differentiate ourselves by taking care of the far end of the venous insufficiency spectrum. My procedures you've seen, most of mine are complicated like yours. So that's how we differentiate. But, when we talk about, and there are venous specialists in the community who send their patients, occasionally to me when the anatomy is complex. So that happens too as a resource. But then, for these overlap syndromes, lymphedema, lipedema, the metabolic overlap within the leg ulcers, the differential diagnosis of things that look like venous ulcers, and, the role of central venous hypertension, elevation, sleep apnea management, all of those type of things that are that the veins are connected to. I think we can help with those type of things.
Yeah. Now, I think that's a great way of looking at it. Suman, University of North Carolina, you guys are also have a lot of vascular people around and vein people around. is it more of a cooperative nature or within the university versus outside the university? Give me a sense of that. And
yeah, it's been really very interesting for me as I've made this transition from a university practice that had almost no vascular surgery, and cardiovascular was, doing the breadth of vascular disease, to now an area that there's a plethora of vascular surgery as well as hematology. So I'm lucky, and I think the others on the call are lucky, because we're in places where they know what vascular medicine is. So the distinctions are well elucidated. For example, I'm now in a group of 6 vascular surgeons who have had a vascular medicine physician with them for more than 10 to 20 years.
Yeah.
And so those distinctions have already been made. I think where the challenge is in areas like Raghu says, outside of university settings where they're not as familiar. So for example, vascular surgeons rotate with us from UNC, and we teach them vascular medicine, we teach them vascular lab interpretation, the medical part of it, DVT care, pulmonary embolism, lytic therapy, all those things, we teach the vascular surgery. So they're more than happy for us to have time with them. So I think it really does depend on where you're situated. If you've had longstanding vascular medicine, those distinctions, and it works very well with vascular surgery, I would say. But if you're outside of that, I think that's where the overlap is a little more challenging.
Yeah, and I think there's an overlap, there's a challenge. And Thom, I'd like you to talk to this. Recently, I did an interview with Frank Veith, and he was very adamant that vascular surgery has done a very poor job in marketing itself, not to doctors, but to the public. And Thom, could you address, do you think the public understands, or do you think you guys need to do a little better job as to marketing your specialty, that the public realizes how you can help them with complex diseases that overlap in so many different ways, that you need a vascular medicine person?
Yeah, that's a great point. The vascular surgeons always do sort of give the impression that they're lost out there in the public, and that people think they're cardiologists who do veins or something. That's always the thing that you hear. With vascular medicine, I don't know that at this point, I've seen our big issues as being one of needing to market ourselves to the public. It's really still been more marketing ourselves to our colleagues, letting our colleagues in medicine understand what it is that we do, because there is such a broad spectrum of things that people do. We have people that are interventionalists. We have people that are purely cognitive, and the cognitive people cover tremendous fields. They cover everything from wound care to, as Raghu said, lymphedema treatment, thrombosis. Thrombosis work is the number one biggest thing that I do. It's a broad area right now, and I think the biggest task has been getting our colleagues to understand, when we can help them.
Yeah, no, I do agree with that as well, because vascular medicine, even though you've been around for so long, you're just beginning to come onto the radar screen of a lot of other people, and they need to understand you're not competing with them, you're helping them, meaning other internists and stuff like that. Let's change gears a little bit. Let me ask you, Raghu, what one or two disease states in the vein side of things do you think we're doing a relatively poor job at this moment in time, and we need to figure out a better way to manage those disease states? So,
I think in the vein world, I think, assessment of anyone presenting with either venous insufficiency or post-thrombotic syndrome, how do we optimize the care for those patients is the key. I think, with the explosion of for-profit OBLs and that kind of stuff, not there are several of my friends, who do ethical practice and do the right thing. But then there are people I've seen just before COVID ended, a patient with bilateral iliac vein stents into the IVC all the way up, and right ventricular systolic pressure was 45. He actually had secondary lymphedema also, and at the OBL he was told that this might help lymphedema. So I think the biggest piece we have, I know AVF and other societies are also looking at appropriateness criteria. You and I have talked about it several times too, but I think that is the most important practice that needs curbed and have better oversight on, I believe, because there's already been a MedCAC panel, 2 years ago now almost, and we will be under scrutiny as a specialty for that. And, that type of practice, especially with more and more venous stents getting on label, it's becoming more and more, a pattern that needs to be curbed.
Yeah, no, I think overuse or abuse is definitely a big issue. I wanted to talk a little bit more about disease states itself. And Yogan, you're very much into the research, the basic science, as Thom already said. What is the hot venous research from a basic science viewpoint at this time? What people are looking at?
Yeah, that's a great question. I think there are quite a few. One is an area of understanding why people get venous insufficiency to begin with. And so there's some genetic studies that suggest that height may be a factor, at least genetic genes associated with height may be a factor, which confirms some historical data. The other part really that we've been most interested in.
Which is kind of funny. Sorry to interrupt, because I don't think that's going to affect anyone on this panel.
I know.
The great thing is you can't tell on a video podcast, right?
I know. Sorry to interrupt, but I had to say.
What do you mean? I'm standing up here. I'm actually not sitting in a chair. That's how short I am.
But understanding how inflammation interacts with vascular disease, and in particular contributes to venous disease, I think is the area that really needs to move forward. And understanding how inflammation can lead to how stretching and distension of veins that are hypertensive can lead to biochemical changes in the vessel wall and create more inflammation. For example, we know that varicose veins or venous hypertension in general can cause a lot of local tissue inflammation. And what that might have in terms of long-term implications, whether it be for thrombosis or vein wall fibrosis and stiffening, those are very different endpoints, but they are things that may originate from the same place. So understanding how that may exist as an entity by itself, and then I think the second part really is understanding how inflammatory diseases and inflammatory disease risk factors can then predispose to either venous thrombosis or.
Yeah, no, I think we have a very good example of that now. We just spoke about with inflammatory disease, with the whole COVID issue and the hypercoagulability. It's clear. I mean, you don't have to be a vascular medicine person to realize the connection between that. So yeah,
that's I think that's really important. We in Southeast Michigan have unfortunately seen a lot of cases of, as you have in New York. And the data is pretty clear that these viruses can actually infect venous endothelium, and that it can create inflammation that then leads to thrombosis. And so I think the world of the vein specialist is going to start getting bigger and bigger with these inflammatory diseases, and whether that's on the medical or procedural side.
Yeah, no, I think you're right about that. Thom?
I could comment.
Is he on the right track here?
Yeah.
Anything else you might consider that we should be looking at from the venous disease viewpoint?
Yeah, absolutely. And again, I don't mean to be self-serving. This is my area of interest and research, but one area we do a bad job in, and a place where we need to do more research, is with venous testing. And I can be very specific here. It's with venous physiological testing. If you think about it, this is one of the biggest gaps we have, and it's something we don't have in the arterial world. Steve, we're constantly seeing incompetent superficial veins that we want to obliterate because we think they'll improve swelling, but we don't have, good ways of measuring, the impact of that reflux. How about with our May-Thurner syndrome, where, we can look at percent stenoses and anatomical things using IVUS and other measures, but is that really producing a hemodynamically significant effect that we're going to be able to fix? This lack of knowledge and knowledge in the testing area is, I think, the biggest single hurdle that clinical venous practice faces today. So again, I'm probably going to go out at the end of my career here just working on this nonstop.
No, I think that is a fantastic point, because, at the various meetings, we make the point, don't treat the image. We all realize the image doesn't tell us about the patient. We say treat the patient, and then we try some way to see how we can treat that patient, what lesions are affecting their venous hypertension or not. But like you point out, we don't have a number that can predict one way or the other, is this going to help this person or not help this person? Suman, have you, Thom is.
Yeah, and I've also, worked on this, and as Thom brought air plasmathography into the practice for this very reason, because it was the closest physiological measure we had in terms of venous outflow. But that, and what Yogen has said in terms of inflammation, the clinical gap that I see that we're just starting to move the ball is really in venous inflammation, and either compression, which we know decreases venous inflammation, but also the use of medicines, including herbal products. And you may know that Susan Kahn has started a Canadian Institutes of Health trial on the use of flavonoids to decrease pain and swelling, the Muffin PTS trial for those with post-thrombotic syndrome. So there's a whole group of, we get these questions about horse chestnut seed extract and flavonoids and that, medical therapies. And as the stents will come back to center, we're sort of at the one end of the pendulum. It's going to be, again, every time, medical therapy, exercise, medicine, compression, lifestyle that ultimately, shows equal improvement. And I think that's that inflammatory mechanism that, Yogen, you're talking about, but also the physiological outcomes that we don't have that Thom is talking about. And, some of us are using AirPleth, but there really is no marker of how volume affects skin disease.
No, I agree. We've got to get a little bit better on the physiological thing. I, as a surgical resident, I got involved with vein disease, doing axillary valve transplants up in Buffalo with Tahari, who was the first one to do it. And at that point, every single patient got a direct ambulatory venous pressure measurement by sticking a needle into the veins in their foot. And Thom, you've been around doing that as well. Yeah. And as direct as that was, still, I would say to you, I'm not sure that if we could do that in every patient now would still give us the answers that we want. It's just not going to do it. But Suman, what you said, and I want you to comment on this. Isn't it always the case with almost any disease that we do a procedure on a patient that the non-procedural component is as important or more important, and they work together in concert? You could do a coronary bypass, a stent, or whatever. You still need all the medicine to help out. And I think you're right. In venous disease, we've looked at it as either you do a procedure or you give them medicine. And we have not gotten that melding of those two things together to maximize the results for the venous patient. So, Raghu, tell me, do you have a program? Do you have some idea how we can better put it all together?
Yeah, you're right. I mean, for example, if somebody has diabetic foot ulcer, right? I mean, and you intervene below the knee, and you go to the extent of venous arterialization or whatever. But unless you offload that diabetic wound, and take care of the underlying diabetes, that's not going to heal. The same thing, applies for, venous disease, just like I alluded to earlier, the overlap syndromes, the phlebolymphedema, the lipolymphedema, the phlebolipoliymphedema, all of these things. And now you add cardiophlebolipoliymphedema if they have the venous insufficiency. So, and central venous pressure. So I believe that all of those things, like we started out our conversation of how the vascular medicine folks can help the venous specialists. I think, that's what you're bringing back here, that, those are the type of things we all need to think about, because the veins, the plumbing system that doesn't work independently, right? I mean, it's pressurized, it's influence, it's third spacing, it's inflammation, and all of those type of things. So I think it's not just this venous disease. Just like we talk about, now I'm done with intervention for CLI. What do I next? Is one of the lectures I gave last year. So the same thing works with with venous disease too. I mean, the venous ulcer is not going to heal unless, you take care of the underlying malnutrition, underlying, obesity issues, and, calf pump dysfunction issues, all of those things.
And Steve, the paradigm is changing in research, and you all know this for the C-TRACT trial, and even in our arterial PAD trials. Now we're randomizing to best medical therapy or procedure plus best medical therapy. And I think that's what you're getting at, is that,
yes,
it's not one or the other in the trials that we're seeing, both in PAD intervention plus, for example, in the Voyager trial, rivaroxaban, that is part of your procedural arm now, is best medical therapy. And so I think you're going to see that paradigm, change as we get into these other trials. For example, for vein disease, it's going to be best compression, for wounds plus, early ablation versus wound care and compression. So I believe that paradigm is starting to change a little bit.
Yeah, I mean, I agree. I mean, just like best CLI is, looking at optimal medical therapy, PAD, CREST 2, CREST 3, all of those are, again, looking at, carotid stenosis, surgical intervention versus best medical therapy. I totally agree. We still don't know what role the DOACs have on post-thrombotic syndrome, prevalence. Yogan might be able to, give us some insight into that. There are older studies where the development of post-thrombotic tissue in the veins may be associated with fluctuations in the INRs. Now that we don't have that with the DOACs, is that a different situation? Steve, like you said, when you do a coronary intervention, you don't expect it to stop there. You have to take your ACE inhibitors, you have to take your, antiplatelet therapy, your blood pressure, your beta blockers and stuff like that. But if you look at any of the venous stent trials, Steve, is there a single trial that, including the C-TRACT or A-TRACT, that mandates a certain medical therapy? No.
No, absolutely not.
And that's not acceptable, in 2020. So,
wait, Raghu, I'm saying this is where you guys can help, to design trials that are going to add that other component so that we can see, what's best. We do need some standardization. I want to ask Yogan something, and we're going to finish up about 5-6 minutes. Yogan, if you could forget about, just fantasize, not about medicine, just fantasize. And if you could come up with a medicine, a pill or something that you think almost every patient with advanced venous disease would take, what would be that type of medication?
Yeah, I think that's a really difficult question, because the heterogeneity of venous diseases is telling that the treatments are going to be different for each of these. Some patients would benefit from an antifibrotic. Some would benefit from something that's more pro-motility in the venous system. And some might benefit from an anti-inflammatory and an anticoagulant. So I don't know if there's a single pill. And I think it really reflects the diversity of patients that we see, for which we really end up needing to look at each patient individually, which is why a vascular medicine and vascular surgeon specialist would partner together on this. Like treating the underlying sleep apnea may not need a pill at all.
Right.
And weight loss is one of the great underutilized treatments in venous disease. And for those, I think we need partnerships like this. So, Steve, I hope it doesn't sound like I'm dancing around the question here, but I think that the patients are diverse, and each one ends up needing to be looked at very specifically for treatments that could be tailored to them. I think for the patients with complex post-thrombotic syndrome, the anti-inflammatory anticoagulants, because the horse is already out of the barn, the anti-inflammatory and anticoagulant treatments end up taking sort of a higher stage.
All right, let me finish up with one last thought that I'd like you guys to comment upon. I think we have spent the last 15 to 20 years in venous disease, what I call the modern era, once we began endovenous ablation, destroying things, destroying varicosities, destroying incompetent saphenous veins. You get it, sclerosing things. I think we need to move, if we can, to an idea of fixing venous disease. And when I mean fixing, meaning beginning to get the patient back to their normal or semi-normal venous function. So in other words, instead of it's easier to rip something out, it's easier to burn something than it is to get a valve to improve or whatever. You guys have any thoughts on this at all as to how we might come about doing this, even from a medical viewpoint? You already mentioned, Suman, about the venotonics, for instance, things like that. I think we should move into the era of fixing now rather than just destroying. Thom.
So something like a new endovenous valve.
Well, that's one thing. That's for the deep system. Yeah, of course. And we're working on that now. And we do have examples already where we are working a little bit more on fixing. For instance, stenting.
Shiva and asphalt.
Shiva and asphalt, yes. Stenting a thrombotic, a post-thrombotic vein that you can reopen. You're trying to get back to semi-normal and stuff. But I think we should take that concept a little bit further and stop, again, doing what we've been doing for hundreds of years. We were destroying veins manually, and now we destroy it endovascular-wise. Thom, you have any thoughts on this?
Well, your point about the valve is that, the valves are really the holy grail of venous disease, where we have a plethora of veins. We have exactly the right number of arteries, but we got way more veins than we need, coming back from any place. So we can always afford to get rid of some. And, if you do wind up with venous obstruction, we're pretty good at opening those things. The real difference, between the arterial and the venous system is those darn valves. And, until we can figure out whether we can replace those or fix them, and whether it does any good, because it's not a guarantee that actually restoring large vein valvular competency is going to achieve what we think it is. But that's really going to be the next big frontier. Figure out how to put new valves in.
Yeah.
Steve, I think Yogan alluded to in his earlier answer, venous disease is so heterogeneous, and just like Thom said earlier, we don't know which one is the bigger culprit to go after in each particular patient, even in whether it's in physiology, meaning is the superficial system contributing to the patient's symptoms, or the obstruction in the deep, or the valvular dysfunction in the intrainguinal areas. We don't know, all the different issues that Yogen mentioned, whether it's motility, inflammation, whether it's obstruction, what is wrong with this? So I think, when you think about designing a clinical trial to test these things, it is just so difficult to find one, cure. We always have said, Steve, you and I talk about there's no cure for venous disease. So I totally agree with you that fixing a problem so that the patients could lead a relatively normal life and postpone all the severe complications, as much as possible until something else gets them, like everyone else is gotten, right? So is probably the best way to do, but I don't know what the answer to that is.
Well, no, I didn't think we were going to come up with the answers on in the next 40 minutes that we spoke here. Suman, you have something you want to say?
Yeah, and I feel obligated as the woman on this to put in a plug for women's health. I mean, we all see a majority of women in our vein practices, and yet there's very little education or even study in pre, antepartum, and postpartum women. We know they make up a lot of our May-Thurner obstruction, and we know that they're the ones that often develop severe vein disease at an early age, and yet there is no counseling at all. And I've made this a focus of my practice. And I think this is an area that is completely wide open for the vein specialist in order to prevent both superficial and deep venous disease. And, I think we can back it up and not wait till it needs fixing, do more education and prevention about, superficial vein disease, postpartum thrombosis, et cetera. That's been a focus of my career, and I think we could incorporate that into every vein specialist.
Yeah, I think these are great points, and this brings out what I've always secretly told. Now I will tell you in public that I've always said that the vascular medicine people are the smartest people in the room. So you guys have helped us with this podcast, showing everybody. I mean, my takeaway here is physiologic testing we're really not that good at, and we really need better physiologic testing to identify, like you guys said, what's going to help the patient and what's not going to help the patient. Yogen, your point about the basic science, the inflammatory aspect is well taken. Suman, of course, women make up the great majority, and I think you're right. We have missing the boat on that as well. And then Raghu, you dealing with Society of Vascular Medicine, being the president and everything else, and incorporating vein specialists into vascular medicine is just going to help everybody take the patients, better care of them in a more cohesive way. And I think people should take that away. The vascular medicine doctor should be your friend. And if you don't have a friend who's a vascular medicine doctor, make a friend who's a vascular medicine doctor. But I want to thank you guys, all four of you who are my friend, for being part of this. I think you've really educated us a lot. So thanks a lot. We hope you enjoyed today's Vein Podcast in association with Radcliffe Vascular. We aim to bring you important topics from the vein world, either topics that we ourselves feel are important or you, our listeners, feel are important. So review us on your favorite podcast app or send your thoughts, comments, and questions to podcast@radcliffe-group.com. That's podcast@radcliffe-group.com. You could also register to access newsletters, videos, and peer-reviewed journal articles. Thank you. Glad you listened. This is Dr. Steve Elias, and we'll see you on the next Vein Podcast.